I want to talk about how GPs can do something to bridge the gap that's been talked about between austerity and mental health. I mean, that's a very speaks of austerity. I've also stuck Brexit in the right-hand corner because that is also hugely relevant in terms of policy, or the complete dearth of policy, not just about health or mental health, but about anything in the country at the moment. So, but all of those things are, as we've been hearing, having major effects on people's health and their mental health. It's a very toxic combination. I want to focus, as I say, on GPs' roles in all this. Just a little bit more context, which actually fits, it's slightly different words, but it fits with what a lot of people have been talking about over the last few hours when I've been listening, about some work we did in one part of Liverpool a few years ago, looking at how the health and mental health were understood, and some very interesting stuff about what we call fields of tension in a number of different domains. Tensions about concepts of well-being, mental health and care. Interesting, there was an example this morning, actually talking about mental health as a problem. It was actually mental health is not a problem, mental health is brilliant, that's what we want. But we get confused about words. We talk about mental health in mental health problems as in some ways very severe, stigmatizing things, and as we had just before lunch, we get them confused with problems of ordinary living that we all experience. From a GP point of view, I've got a particular idea of the area and the community that I work in, because that's my practice, that's my practice list, but that's not the same area or the same community as would be understood or experienced by other people actually living in the same place. They may have a community based on religious or political or ethnic or whatever grounds. So we can't just read those two things together. The positioning of primary care I'm going to talk about, but I mean certainly an issue that came out of that study, and I think we've been hearing from people, is the sort of increasing anxiety, understandable anxiety within primary care about our ability to deal with all the stuff that's coming at us, and our sort of wish and desire, whether public or private, to sort of to try and push it away, marginalize it from our own work. And again, I'm going to come back to what we've been hearing about the dynamics of resources outside the medical zone. From a GP's point of view, we tend to ignore and forget that, and I want to talk about why we don't need to and shouldn't do either of those things. And then one particular thing which I don't need to tell either Marta or Richard, because you know this already, is about the dangers of medicalisation. And this is just an example. It's actually an example from a study in Australia a few years ago, and it was a study about people who were migrants from other parts of the world. And one of the quotations, this is a very typical thing, when one of the migrants from East Timor, they were being asked what their impressions were when they arrived. This is what they were talking about. How cold it was, and how deserted the streets were, from the massive changes from where they came from, and they didn't know how they were going to start a new life, and that was their continuing worry. It was a worry about culture, about society, about huge things. And the GPs who we talked to in the study, very nice, decent GPs, said, in some cultures they don't understand depression as a condition that needs treatment. So the point from that, and this is something that I urge family doctors when I talk to them, is to be careful not to use the diagnosis of depression as a mechanism of decoupling, as a way of replacing loss with illness, as a way of individualizing previous social problems. But you folks know all that, so the question is, what do we do as GPs to make things a bit better? Well, I think we can do what any citizens can do. We can vote for local or national parties that are more likely to help us get the things we need. We can advocate, as citizens. But we can also, and this is what I want to talk about, we can also develop partnerships. We can develop partnerships with patients, one-to-one in the consultation, with our colleagues, whether in primary care or elsewhere, but also very much with local communities. And I want to tell you for a few minutes about some work I was leading a few years ago now, up in the northwest of England. It was called the AMP programme. It was a 5-year funded by the National Institute for Health Research. And the key element of this was we were looking at mental health of people from marginalised communities. And some were white ethnic communities, some were minority ethnic communities, but all with severe socioeconomic deprivation. And what we came up with was a 3-part model of community engagement, of looking at primary care, and of developing focused and targeted psychosocial interventions. So it wasn't or, it was and. So and we did some fairly simplistic randomization to see which effects, but I'm only going to give you one example of how that might have had an effect. So, but I just want to talk you through each of these 3 bits for a couple of slides each. So the community engagement, this involved working within a local self-defined community, working with local community leaders to map out what the existing resources were, identifying from the community a community champion, so someone from that particular area who had high local credibility, but and was also in a position to converse with academics, so who could make that bridge with academics and clinicians. And then we set up a consultative focus group to work out some priorities, and then a community working group to actually get stuff to happen. A consultative focus group involved all of these sorts of people. So people from third sector organisations, health commissioners, the police, very important. That was sort of what Tony was talking about this way. We didn't need tasers and things, but the community police were actually a crucial element of this. Local politicians, the research team, faith leaders, community nurses and GPs getting together over a series of meetings over a 2-year period to think about what were the issues in the area that were of relevance to mental health, very, very broadly defined. Think about what we can do now, what needs to happen over the life cycle of this 2-year program, and what we can do to build the program into sustainable issues for the longer term. So that's sort of the community element, and as you saw on the previous slide, GPs, community nurses, members of the primary care team were part of that consultative focus group. So we were involved, we were engaged there. And then we did work in primary care teams themselves, looking at 3 areas: knowledge transfer, systems review, and active linking. And just to say a little bit more about each of those, the knowledge transfer, this was stuff where the primary care team decided for themselves what they needed to know, which would enable them to better help their, to better improve the mental health care of their disadvantaged patients. So we gave them some presentations about common mental health problems as they might affect, for example, older people or the BME community, and in a couple of areas that they actually wanted some advice about the medical legal problems of asylum seekers, who are a very important subset of that. Within the practice, we looked at making appointment systems more accessible for people from disadvantaged communities, better use of interpreter services, and then we were also helping the practice to link to be more aware of the resources that were available in their communities, and there were some astonishing examples of practices just literally within walking distance of, like the one I'm thinking about, there was a very effective local mosque with a very with all sorts of services. The practice simply didn't. Well, they'd seen it, but they had no idea what was possible. And offering referral from one way to t'other. And then the third element were the psychosocial interventions themselves, which were tailored specifically to the needs of the particular groups we were looking at, older people or people from South Asian or from Somali backgrounds. At the centre of this was an idea of the patient themselves as an agent of change, so it wasn't being done to them, it was working with them. Working with wellbeing facilitators who would offer some active case management and some either individual or group or signposting activity depending on what the particular person was looking for. And this is just one interesting bit of data. There's lots of stuff. This is just one example of how those three interconnecting things work together. That in areas where we were doing active community engagement, we were much more likely to get people referred in to the psychosocial intervention. So that's CE plus versus CE minus, whether it was with older people or with people from minority ethnic groups. So there's something, the cogs were actually working together and actually making a difference to each other. And then something I'm working on now is something called Problem Management Plus. This is something which is approved by the WHO. We're actually using it in Liverpool to improve the mental health of asylum seekers and refugees. The key thing here is that this is delivered by lay therapists. So this is something where the members from the local community, in this case a refugee community, but it could easily be a community in a deprived area, are given some training in order to be able to develop the skills to deliver a very well-attested intervention to help people with their problems. Again, with a strong emphasis on agency at the level of the participant. So that's a run through things. And so my conclusion for the GPs among us, is that we are indeed necessary people. I'm glad we're not redundant, we're necessary, but we are not sufficient. We're not in the position of authority within communities, we're in a position of authority. And so I think it's our opportunity and our obligation to both decenter, but then also to reconnect. Thank you very much.